Hey everyone, this is James here, and this is my HPO, HPA, and functional hypothalamic amenorrhea presentation. So starting off with the HPA axis, that is the hypothalamus, anterior pituitary, and adrenal glands. At the hypothalamus, we begin with corticotropin releasing hormone, which is CRH. And then that moves into the anterior pituitary to synthesize and create adrenocorticotropin hormone, ACTH, and then that gets released into the systemic circulation, travels to the adrenal glands, and cortisol, which is synthesized de novo through cholesterol, is released from the adrenal glands and into the systemic circulation. Here's a visual for the HPA axis. Again, you can see, let me just make sure. Yeah. Start at the brain, paraventricular paraventricular nucleus that's in the hypothalamus. Again, that moves to the that secretes CRH. Now, we're not going to talk too much about ABPN right now. And then that moves to the anterior pituitary, which then again creates ACTH, moves to the adrenal gland, creates cortisol, which feeds back to the anterior pituitary and the hypothalamus in the brain to inhibit CRH and ACTH. The HPO axis, again, hypothalamus, anterior pituitary, and now we replace adrenal glands with ovaries. Again, we're beginning at the hypothalamus with the release of gonadotropin releasing hormones, which its pulsatility is either in a rapid or slow pulsatility, which rapid preferences LH and then slow preferences FSH. And then this also has a surge mode, which it's a positive feedback system from estrogen, which goes to the hypothalamus, and that high amount of estrogen stimulates a it's an overloading surge, which preferences LH, and then that secretes more, or that heads to the follicle and the ovaries to release the egg. Goes through a whole mechanism of actions that essentially releases the egg. Once the egg is released from the follicle, FSH is not completely inhibited, but it slows its release. And then progesterone, it becomes the not primary, I would say primary with in the luteal phase. Progesterone becomes the primary hormone um, as the follicle that was once holding the egg becomes the corpus luteum, and then that releases uh, progesterone in preparation for pregnancy. Estrogen is still high in the luteal phase, just not as high as it was in the um, follicular phase, mid to late follicular phase. Here's a visual. We won't focus on this left side too much. It's focusing on men's aspect, but if we're looking at the HPO, again, hypothalamus, GnRH to the anterior pituitary, which LH and FSH, as they travel the ovaries to stimulate granulosa cells and theca cells to produce estrogen. And then as the follicle becomes the corpus luteum, that stimulates progesterone, which again both feed back to the anterior pituitary and hypothalamus to have a negative feedback. So again, for the hormonal regulation, both HPO and the HPA are operating on negative feedback mechanisms, whereas the HPO does have that positive feedback system where the high levels of estrogen prior to ovulation stimulate the increased amounts of LH. Essentially, this is all to maintain homeostasis, right? Too much of one hormone on either side, right, and either axis uh, leads to complications that aren't really covered in this presentation, but complications within the endocrine system and throughout the peripheral tissue. So here's a visual of the interaction between both of them. I'm more of a visual person myself, so that's why I really like these. If we start on this left side at the PVN, the paraventricular nucleus, right? This is all happening in the hypothalamus, both these two nuclei right here. Um, CRH, we're going to focus on the HPA axis on this left side. So the PVN secretes CRH, which travels to the anterior pituitary, which then synthesizes ACTH and releases it to the adrenal cortex. And this graphic uses glucocorticoids, but we're still calling that cortisol because it is a glucocorticoid. But and then cortisol again feeds back to the anterior pituitary, the hypothalamus to inhibit CRH and ACTH. But interestingly enough, well, hold on, let me backtrack. We'll go to this right side. The POA, the preoptic area, synthesizes GnRH and secretes it. GnRH goes to anterior pituitary. Again, we have FSH, FSH and LH, which not focus on that, which goes to the gonads, in this case, the ovaries, to induce estrogen and progesterone production. We won't go into that again, but those are the hormones secreted from the ovaries. And then again, these have that negative feedback or positive feedback, depending on the menstrual cycle phase, on the anterior pituitary and the hypothalamus. Coming back to the cortisol side, you follow this arrow all the way up. Cortisol has there are CRH receptors and glucocorticoid receptors on the preoptic area nucleus in the hypothalamus, which inhibit the production of GnRH. And we can see here in the CRH that also inhibits the production of GnRH. And if you follow this CRH little arrow, it goes to the arcuate nucleus, which is another portion of the hypothalamus, but it stimulates the production of beta endorphin. And then that comes from the arcuate nucleus, and that also inhibits the production of GnRH. So a lot of interaction between the two, regardless of how it looks, where like cortisol is just completely shutting down the um, the HPO axis. Even in a homeostatic state, this is always happening, right? The whole goal of the endocrine system is to maintain homeostasis, and so that the body is just functioning as normal as possible. So this isn't necessarily an issue. It becomes an issue when cortisol or this entire HPA system becomes overly activated, which we will see in a second. So functional hypothalamic amenorrhea, or FSH, or not FSH, FHA, sorry. It's the complete cessation of the menstrual cycle uh, due to the suppression of the HBO axis. And this is a result of ultimately stress, but commonly it's seen in young athletes that these three things are the issue: disordered eating, psychological stress, and then excessive exercise. And it's not mentioned too much in literature, but I would say it's heavily implied that the lack of recovery adds to these, it compounds all these, right? If I have all of these three things going on and I'm not in a recovered state or actively recovering, the likelihood that these kind of expand the issues just increases. For the diagnosis, it's 3 months with amenorrhea, less than 50 picograms per milliliter of estradiol, and then less than 10 millimeter international units per milliliter of FSH and LH. Again, I mentioned younger athletes, but this commonly occurs in premenopausal women, and it results in anovulation and infertility. Interestingly enough, it is reversible, and we'll cover a little bit more of that in a bit. So this is the interaction between FHA, HPA, and HPO. We kind of already know how cortisol interacts with the hypothalamus, the HPO axis. But as I mentioned earlier, right, the HPA and HPO axis, they're meant to operate together, maintain homeostasis. But in that FHA state where we have increased cortisol, like extremely increased beyond normal conditions, it's going to feed its way back. That's what this little line is. The picture cut off, but it feeds back to the hypothalamus, ultimately, again, inhibiting GNH neurons, GnRH secretion, sorry, which then further reduces FSH, and LH, and then results in decreased estrogen because the body doesn't have the necessary hormones to produce the estrogen. Won't cover too much of the additional items, but it's crucial to the endocrine state that a person is in. And over here on the right, we just have different issues that are you're experiencing, which we're going to cover a little bit, not too in depth, but low bone mineral density, increased fracture risk, again, amenorrhea, infertility, endothelial function, which will cover some cardiovascular issues, some thyroid issues, cognitive impairments, depression, anxiety. Right. So it's a widespread issue that affects many systems of the body, not just endocrine, but a multitude of systems. Again, some consequences we have cardiovascular. Osberg, it all uses it was a study of individuals with Turner syndrome and primary ovarian dysfunction. And Turner syndrome is a genetic issue where the body has lifelong estrogen deficiency due to genetic issues at birth. But essentially, uh, what Osberg et al. Saw was that individuals with Turner syndrome and ovarian deficiency had significantly thicker carotid and intimal medial thickness, or CIMT. And this is just a clinical diagnosis for atherosclerosis. So, uh, in essence, the literature is using Turner syndrome as a correlation or an example of what estrogen deficiency looks like, which is prevalent in individuals with chronic FHA. If we look at bone issues, Grinspoon found that increased cortisol levels had an inverse relationship with osteocalcin. Uh, so increased cortisol, decreased osteocalcin, which is a marker of bone formation. And estrogen typically operates on osteoclasts, which are more for bone resorption. And even though their effects do, estrogen effects do bleed over to osteoblasts, the primary effects of bone resorption are depleted, which essentially result in a net of bone mineral density, despite osteoblasts potentially operating as normal. If the formation exceeds the rate of resorption, then there's going to be a net loss of bone. And so that's what we're seeing here. And Grinspoon's, it's not exactly what we're seeing, but it's likely what we're seeing with the reduction in osteocalcin. Psychological consequences. Marcus et al. Found that women with FHA have a higher depression, anxiety scores, and an inability to cope with daily stressors. And then fertility. I forgot which. Oh, Shutfield et al. It's in the references, but they directly mention that there are a few studies that directly assess fertility and FHA, which I don't think that's a surprise because I think logically, the literature knows that FHA is a succession of the menstrual cycle, and without the menstrual cycle, there's obviously there's no possibility of getting pregnant. So I know we don't typically cover treatments in in our class, right? It's just like highlighting the disorders or dysregulation within the endocrine system. But I think it's important to know and to understand so that way we can bring it to not only different athletes and coaches, but if we are working as a team, a health team, whether it be at a hospital or some sort of clinic. So the treatments that I've found were initially just to identify the etiology. So sometimes it's a combination of these or of these three. It's not always all three happening at once. Sometimes it's, disordered eating and excessive exercise, and maybe that in its own is inducing elevated stress levels. Or maybe the exercises um, adding excessive stress, and the disordered eating is, reducing the energy availability for the body. Brega et al. They conducted 16 cognitive behavioral therapy sessions over the course of 20 weeks, and 7 out of the 8 women showed an increase in ovarian activity, with 6 resuming normal ovulation. And I think cognitive behavioral therapy is an interesting approach because it's not. I know there's all these pills over here, but it's not a pill related. It's not necessarily exercise related either, right? Because exercise is something that contributes to this, but it's a way for um, I'd say individuals to uh, get a outside perspective on their actions, right? Someone is speaking to them about, hey, how their eating is affecting them, how their inability to handle stress, if they have help, maybe they're not taught how to handle stress, and then the behavioral therapy kind of helps give you those tools. Um, and I know it's really not our realm as like exercise specialists, but if like the cognitive behavioral therapy is done with an exercise specialist, right, in conjunction, right, with a health team or something like that, uh, I would say our realm is this area, helping people realize what excessive exercise does to the endocrine system and the body in general, combined with a lack of recovery. So um, that may be our space in the matter in the future, or maybe people are doing it right now, but I think it's important to know the treatments of the matter. Here are the references. Thank you for listening. Appreciate it. If you guys have any questions, please comment below. Thank you.